Welcome to Precipio Learning's free sample review of the cardiovascular system. I'm Dr. John Athas, a professor, and I'm a former practicing MD. In this free sample, we cover just a few of the cardiovascular topics covered on the PANCE and the PANRE. Precipio Learning offers a complete and comprehensive test prep review course for the PANCE and the PANRE. We have had tremendous success in helping students pass both the PANCE and PANRE with our tutoring technique, and I urge you to please visit our website at www.precipiolearning.com for more information. Thank you. Regulation of blood pressure and of blood flow. Cardiovascular center in the medulla oblongata regulates heart rate and stroke volume. Stroke volume is the amount of blood ejected from the left ventricle after each contraction. An acidosis results in a tachycardia and an increase in the cardiac contractile force. Baroreceptors are found in large arteries. These are pressure receptors. Think of them as small cystic structures that, when compressed, either digitally, in the case of the carotid baroreceptors, or by an increase in blood pressure, by hypertension. And when these are compressed, there is a direct connection from these baroreceptors via the vagus nerve to the sinoatrial node and peripheral vasculature. Hence, with compression of these during a hypertensive episode or after manual compression, the blood pressure falls with arteriolar dilatation and the pulse drops. Hence, during a Valsalva maneuver, when patients are straining, for instance, this is the cause of many admissions to emergency rooms. The patients may be sitting on the toilet, straining at stool, perform a Valsalva maneuver whilst straining, and create a vasovagal response serious enough to cause a syncopal episode and thus transfer to an emergency room. Carotid bodies and aortic bodies. We have chemoreceptors that detect the presence of oxygen, carbon dioxide, and hydrogen ion molecules. Hypoxia, of course, means low oxygen content in the blood. COPD patients' respiratory rates depend on oxygen levels. In the normal healthy person, it is the carbon dioxide level in the blood to which the cardiovascular center in the medulla oblongata responds to. Acidosis means an increase in H ions or carbonic acid in the blood. Hypercapnia means excessive carbon dioxide in the blood. Our respiratory rate partially depends, again, on this level. Metabolic acidosis is an arterial pH below 7.42 due to circulating H ions. Respiratory acidosis is an arterial pH below 7.42 due to high levels of circulating carbon dioxide molecules. Here we have the cardiac conduction system. It's a very nice pictorial showing the two atria, their respective ventricles, as well as the hardware, if you will, of the electrical conduction system itself. Take a look at the roof of the right atrium. We see the sinoatrial node. which is our main pacemaker. It has an inherent firing pace of 72 beats per minute. This would be at rest. Below that, we see the atrioventricular node. So taking a look at the arrows emanating from the sinoatrial node, we see how once it fires, it spreads a wave of depolarization throughout both atria. After all, it is the job of both atria to contract and dump their blood into their respective ventricles. Once this wave hits the atrioventricular node, then the atrioventricular node depolarizes and sends its own signal down the AV bundle. It should be noted there is a very small millisecond delay in the atrioventricular node. This gives the atria a little bit of time to dump their blood into their respective ventricles. So the atrioventricular node depolarizes and then sends its signal down the AV bundle. Here we see the right bundle and the left bundle, which will carry on the electrical impulse delivered to it from the AV bundle, and the impulse travels down both bundles simultaneously, continuing on to their respective Purkinje fibers. On this note, imagine, if you will, what would happen if one of these bundles is diseased, perhaps from ischemic cardiomyopathy. In that case, the depolarization or the electrical impulse that's traveling down that bundle will be a bit delayed. As we know, when the impulse travels down both bundles simultaneously, it gives us the R wave deflection on our EKG. But if there is an ischemia in one of the bundles or some other type of malady, then that bundle, be it right or left, will depolarize more slowly. Thus, we will wind up with two R waves. Hence, we will have a bundle branch block. Okay, let's start off with the basics of EKG interpretation. First things that we do when we look at an EKG is to look at the rate and then the rhythm and the PR interval and ST segment abnormality, if any. For the rate, we count the big boxes in between R wave peaks and then divide that number into 300, and there you have the ventricular rate. We question next, is the rhythm regular? So then we can measure the distances between R wave peaks and also between P waves. And if those intervals are the same, then we have a regular rhythm. Next, we look at the PR interval, and if the PR interval is greater than 0.2 or larger than one big box, we have at least a first-degree AV block. Flat ST depressions mean ischemia, and an ST elevation means an MI in progress. ST elevation means, quote, a current of injury, end quote. And a Q wave deeper than one small box is a completed myocardial infarction. We use leads 2 or AVF to look at P wave morphology. Chest leads help pinpoint where a problem is arising from. So that V1, which is, quote, looking at, end quote, the right ventricle, as well as V2, may be considered right-sided leads. V3, which has, quote, looking at the septum of the heart from where it is placed in the precordium, should be considered a septal lead. V4 and V5 would be left ventricular leads, and V6, which is essentially higher up, if you will, on the left ventricle, would be a high left ventricular lead. Chemoreceptors and baroreceptors. Here we see on the left-hand side the chemoreceptors. We see the carotid body, which we find on the external carotid artery. We see the right subclavian artery that has another chemoreceptor. On the right side, we find baroreceptors. Once again, of course, here we find in the internal carotid artery, just at the takeoff, a baroreceptor. This is the one that is sometimes palpated by the practitioner when the patient comes in with a tachycardia. And on the monitor, we are not able to determine whether or not this is a sinus tachycardia or some type of reentry phenomenon, and so forth. Thus, by slowing down the pulse and widening out the QRS complexes, we're able to better determine what the situation is. Below, we find an aortic body with quite a large baroreceptor. Cardiovascular blueprint. Below, we have a sample of some of the NCCPA's cardiovascular blueprint topics for the PANCE and PANRE. In the complete Precipio Learning Review course, we review all of the blueprint topics in detail. Additionally, I will be available to my students to discuss any specific questions they may have over the phone. Coronary heart disease. Well, coronary heart disease means a narrowing of the coronary arteries by arteriosclerosis or atherosclerosis. Arteriosclerosis is that hardening of the coronary arteries and all of the arteries throughout the body, usually from hypertension. Atherosclerosis involves atheromatous change in the intima of arterioles. And usually this is a result of high plasma lipid levels associated with a high LDL-HDL ratio. We can have atheromas in coronary arteries that may fracture, throwing off an embolism to the myocardium, causing an MI. So acute myocardial infarction, here we have a through and through necrosis of an area of the myocardium, usually in the left ventricle. The causes are genetic predisposition, what with a hyperlipoproteinemia, high LDL levels. Other causes are dietary indiscretions, lifestyle, and ST elevation on EKG means there's an acute myocardial infarction in evolution. It's underway. We treat this with TPA, sublingual nitroglycerin, aspirin, and in the hospital, percutaneous interventions within 30 minutes. This might mean balloon angioplasty of a coronary artery, along with anticoagulation and thrombolytic administration through the catheter directly into the coronary artery. Non-ST segment elevation, this is an infarct without ST segment elevation, which means it is a subendocardial non-transmural MI. So we look at these as if they are a sunburn, if you will, of the heart. And the treatment here also is quite similar. And it's going to be aspirin, TPA, and percutaneous intervention, PRN. And of note here, an ST segment elevation that evolves into a Q wave indicates the completion of the transmural necrosis of a portion of the heart. A through and through necrosis of the myocardium. Angina pectoris is ischemia of the myocardium from coronary artery disease. Stable angina is usually exertional angina. This may be physical activity, mental stress in a person who has coronary artery disease. And when labeled stable angina, the angina is relieved with nitroglycerin. Aspirin daily is prescribed for these patients. Unstable angina pectoris is angina at rest or angina not relieved with nitroglycerin sublingually, Q5 minutes times 3. Treatment, calcium channel blockers, and daily aspirin. In these patients, of course, we would want to perform coronary angiography to take a close look at the coronaries. Prinzmetal variant, Prinzmetal angina, is a vasospastic disorder. Coronaries are clean. However, there's associated vasospasm causing ischemia to the myocardium. EKG may show ST elevations, and then on coronary angiography, we see that the coronaries are indeed clean. So these patients need to be treated with calcium channel blockers and or time-release nitrates. Propanolol here is contraindicated. Thank you. I hope you've enjoyed this free sample review of the cardiovascular system. Our PANCE Exam Prep package costs $395 for 12 months. It includes a 20-hour virtual class test prep course lectures, comprehensive PowerPoint review slides, and test prep pearls. Please visit our website at www.precipiolearning.com.